Hello, everybody. My name is Sidharta. Arta, you can call me. I'm going to share just a bit about critically ill COVID-19 management in tertiary hospital in Indonesia. Okay, as a background, COVID-19 in Indonesia, it started in March 2020. As the third week of November of 2020, we have more than 34,000 confirmed cases. We have about 2,000 to 4,000 cases every day. And then this is such a national burden for us. And our government also has a website. You can look at this one. Okay, this is the rates of COVID-19 cases day by day. So we right now is still on the first wave, you can say it, first wave. So it's never been going down. And then this is the mortality rate. We have a highest mortality rate with the older person. And then we have a problem in ICU bed occupancy. Right now, we have a shortage, but I think our government starting to open more and more ICU beds. So I hope we will have enough ICU bed soon. This is our hospital. Our hospital is Cipto Mangunkusumo Hospital. It is a tertiary hospital in central of Jakarta. We have a standalone COVID building called Kiara since April 2020. We already have more than 200 or 300 COVID ICU cases. We are top referral hospital, so mostly our patient is with comorbidities and with highest SOFA or Apache score, so with high mortality. Our ICU style, we have a control room. We call it green room, so safe room without using a third level PPE, and patient room, and also with integrated central patient monitoring. We have 10 beds. So 2 nurses is taken care of 3 patients. We have 30 nurses total with 3 rotating intensivists. We have also 3 to 4 pairs of medical officer or resident, and we have other specialties also in our ICU. So this is our ICU. It's negative pressure ICU. For the case one, because this is a case series, is a woman 52 years old with BMI of 46. She was admitted to our ICU with progressing shortness of breath. She was already intubated and on mechanical ventilation in ER. She has a positive contact tracing with her husband, but her PCR result is not available yet. She stayed in our ICU for 16 days. We secured central venous and arterial line. Her initial PaO2 over FiO2 ratio was less than 150, so we pruned her. She was still fighting, so we initially gave her a combination of sedation and analgesia drugs infusion, also with muscle relaxant infusion to reduce her breathing effort. Then she was maintained in prone position for 18 hours, and then after we supined her, her PaO2 per FiO2 ratio improved and then maintained more than 250 millimeter mercury. She was started on dexamethasone from the first day, then, but her initial PCR result was negative, so we did not give antiviral treatment. But during the 7th day, her second PCR result was positive. At this early period of time, favipiravir or remdesivir were scarce in our hospital, so we started oseltamivir because this is such our early cases. At the same time, we also start azithromycin. For anticoagulation, we start heparin unfractionated from the first day. During the heparin course, she developed thrombocytopenia, but can also be cause sepsis. So we stop it and we start enoxaparin. After 6 days of enoxaparin, she had a bloody sputum, and then we stop enoxaparin. But the next day, the bleeding stopped, and then we start the unfractionated heparin with reduced dose. She developed secondary bacterial infection with Enterococcus faecalis, and then we adjusted our antibiotic based on sputum culture resistance, and she responded well. Her general condition was getting better on the 10th day. During the weaning process, she was self-extubated because we decreased the sedation too soon. During bridging toward reintubation, she responded well to rebreathing mask. So we switched to high-flow nasal cannula. Her daily fluid balance were mostly slightly negative. Her cumulative fluid balance in the last day of the ICU was negative 3,784 milliliters. 3 days later, she can be discharged from the ICU. This for our second cases. We have 45 years old women with a confirmed case with a long-standing diabetes mellitus type 2, hypertension, and history of stroke. She contracted COVID-19 from her college 10 days prior, so her PCR was already positive. Her condition continued to decline despite antiviral, favipiravir, anti-inflammation, dexamethasone, anticoagulation, heparin, convalescent plasma, and oxygen therapy in ward. She stayed in our ICU for 22 days. During the ICU care, she was intubated and was put on invasive venous and arterial pressure. She developed supraventricular tachycardia, which was amenable to antiarrhythmia therapy. We used amiodarone. She needed combination of sedation and analgesia also to be able to achieve comfortable condition. At one point, she needed 4 combination of sedation. We finished her favipiravir and dexamethasone treatment. We also continue unfractionated heparin, but because of thrombocytopenia, we stopped it. After her thrombocyte value was normal, we start low molecular weight heparin from the Parinux until she was discharged from the ICU without any sequel of bleeding. During her ICU care, she developed 3 episodes of secondary bacterial infections, and we switched antibacterial treatment based on blood and bronchoalveolar lavage culture resistance. Her serial procalcitonin level also correlated with clinical signs of infection. And then she also developed fungal infection, Candida albicans, based on blood culture, and we started antifungal therapy. During her care, our team decided to give her 3 days of IVIG treatment with good result, improving hemodynamic and lowering of inflammation and infection markers. She also had a session of CRRT and blood purification therapy because of positive fluid balance despite furosemide infusion. Her condition began to markedly improve after 2 weeks of ICU care, and she was extubated on the 20th day. At the end of the ICU care, her cumulative fluid balance was negative 185 milliliters. So we have our local therapy of COVID released by our country, and then we use this to based on our therapy. So our guidelines in our hospital is very open, dynamic, and some of them are part of RCTs. We have our local COVID board. Our antiviral that we use oseltamivir in the early days, favipiravir, and remdesivir. Some of this was part of the trial, like remdesivir. We are part of Solidarity trial. We have dilution issues with remdesivir because we need to dilute it with 500 cc of normal saline, and we need to give it like in 1 hour. So it's like giving fluid bolus for the patient. And then we also take care of hepatic and renal function. For anti-inflammation and immunomodulator, we use steroid, dexamethasone, methylprednisolone, colchicine, pentoxifilin, and azithromycin. We also look for side effects like high random blood glucose, diarrhea, prolonged QT interval, and hematemesis and melena. We also use some special high-cost therapy based on our country, like IVIG, therapeutic plasma exchange, blood purification, CVVH, and tocilizumab or Actemra, but not to every patient. Only this is issued by our COVID board, so it's not for every patient. We check interleukin panel before and after every therapy. And for anticoagulation, we use unfractionated heparin, fondaparinux, and enoxaparin. We have the complication that is mostly often is bleeding, but we didn't check antithrombin 3 and factor 10A. We check it, but not routine, not for every patient. For respiratory supportive therapy, for oxygen support, we use high flow nasal cannula and non-rebreathing mask. We rarely use non-invasive ventilation by mask. Only 2 cases so far. We use high flow nasal cannula as post-extubation oxygen therapy with good result. For mechanical ventilation, we use pressure control, assist control, and SIMV. With driving pressure always less than 15, with PIP 6 to 12, and FiO2 40 to 95%, with tidal volume lower than 8 cc per kilogram body weight. We also use APRV. We use resusview.com for the protocol. For mechanical ventilation, it's individualized, no magic bullet. So we look at the patient. If the patient responds well to PC or assist control, then we use it. But if the patient respond to APRV, then we use APRV. We also check daily blood gas. And prone position, this is such a learning curve for us. Before the pandemic, we never do prone position, but right now it's almost become routine. So we know we have a responder and non-responder. Most of responder only need one prone session in the beginning, and we know that the earlier we do the prone position, the outcome is better. Like this is our 2 cases, and then 18 hours. We use prone position for 18 hours. We need to do hemodynamic assessment before prone, usually by our cardiologist. And initial days we have complication, a lot of sores in the face, but right now it's getting more seldom. And also for respiratory therapy, we sometimes use bronchoscopy on selected cases, like the cases with purulent sputum. For hemodynamic aspect, we monitored MAP, organ perfusion, organ function, and lactate trend. And we use advanced hemodynamic assessment, routinely echocardiography by our cardiologist, but only for patients with risk factors. We just had pulse contour analysis device. We are hoping for better hemodynamic management from now on. Most ICU patients had central venous catheter and arterial line. For central nervous system, we use sedative agents like midazolam, propofol, dexmedetomidine. Dissociative agent like ketamine. Most of the patient, I think all of the patient, need multiple combination. Inadequate sedation lead to catastrophic self-extubation or venous or arterial line or a urinal catheter disconnection. So sometimes we need to do restraint, but we need to have an informed consent from the patient or the family. We kind of see like our survivor, the one that survive is alert and comfortable even with multiple sedation and analgesia. But for non-survivor, usually the CNS central nervous system is not getting better. For secondary NCO infection, it's pretty common after 1 week. So the dry airway become purulent sputum. For patients with high candida score or colonization, we give antifungal. For antibacterial culture, we use blood, sputum, urine, bronchoalveolar lavage. And then often we have a MDR organism. And then we adjust our antibacterial therapy by culture resistance. For fluid management, we mainly use isotonic balanced crystolite for resuscitation and maintenance if needed. We never use synthetic colloid. And then we give albumin transfusion, but on selected cases, because it is very expensive in our country, we give it for correction of the patient albumin level if it is lower than 2.7 gram per deciliter, or for fluid resuscitation we use albumin 5%. We believe dry lung is healthy lung, so we maintain 0 to slight negative balance for daily fluid balance. We achieving negative balance by spontaneous diuresis, furosemide, or CRRT. We always have a electrolyte check every day because we know we don't want any disorder in electrolyte. We are also avoiding extreme negative balance. And then for replacement, we use balanced fluid therapy, except for patient with hyperkalemia, we use normal saline. So our take-home message is we are still trying to grasp the situation, and then we know that the therapy is still evolving, so we need to be open-minded. What regards a good therapy right now might not be tomorrow, so we are open-minded. And then full government support. We hope it will last until the pandemic is over. Our government is trying very hard to support us, and then we can feel it. And then I hope it will be a success. So we have organizational learning curve and also individual learning curve. And then we will never give up. Okay, I think that's all. Thank you.